Today's topic HUS, Hemolytic Uremic Syndrome, ITP, Idiopathic or Immune Thrombocytopenic Purpura or Hemophilia. First, Hemolytic Uremic Syndrome. Hemolytic Uremic Syndrome is triad of microangiopathic hemolytic anemia, thrombocytopenia and acute kidney injury. So, there will be anemia, thrombocytopenia, renal failure. Most common etiology is diarrhea associated hemolytic uremic syndrome. Causative agent or organism is Shiga toxin producing E. coli. Okay. E. coli subtype O157H7 and O104H4. Important for MCQ. Shigella dysentery type 1. So, diarrhea associated hemolytic uremic syndrome causative organisms are E. coli and Shigella dysentery. Then hemolytic uremic syndrome due to other infections like Streptococcus pneumoniae or pneumococcus, influenza and HIV. Atypical HUS. Atypical hemolytic uremic syndrome due to complement regulation like deficiency of factor H or deficiency of factor I and C3 deficiency. Then TTP, Thrombocytopenic Purpura, that is due to ADMTS deficiency. Then drug induced cyclosporin and tacrolimus. SLE, systemic lupus erythematosus, malignancy and bone marrow transplant. So, these are the causes of hemolytic uremic syndrome. Now, what are the pathogenesis behind this? In diarrhea associated hemolytic uremic syndrome, Shiga toxin or verotoxin produced by E. coli bind to endothelial cells in the glomerulus and causes endothelial damage. So, that leads to AKI, acute kidney injury. Then activate platelets to promote aggregation, that will cause thrombocytopenia and causes mechanical injury to RBC, that will cause hemolytic anemia. So, HUS was the triad of anemia, thrombocytopenia and renal injury. Then in pneumococcal associated hemolytic uremic syndrome, their neuraminidase enzyme exposes T antigen, then IgM antibodies bind to it that T antigen that triggers hemolysis and resulting anemia. What are the clinical features? Patient will come to us with complaints of fever, vomiting, pain abdomen, diarrhea, okay, fever and mostly GI complaints. Then subsequently the patient will develop pallor, weakness, lethargy, renal insufficiency depending on severity, mild to moderate renal failure to severe. Then hypertension, renal injury will be there, so hypertension, focal or generalized seizures, encephalopathy, CNS involvement will be there in advanced stages, and patients with pneumonia associated hemolytic uremic syndrome come with pneumonia, empyema and bacteremia. Now, diagnosis, what are the investigations or lab investigations? First, anemia with Schistocytes, hemolytic anemia. So, anemia will get anemia with Schistocytes. Then thrombocytopenia, increased reticulocyte count. As we get in cases of hemolytic anemia, reticulocyte count will be high, blood LDH, lactate dehydrogenase will be high, haptoglobin will be reduced and negative Coombs test will be negative except Streptococcus pneumoniae or lupus associated HUS. So, again it is important for MCQ. Streptococcus pneumoniae and lupus associated HUS, Coombs test will be positive. Then in urine, we will get microscopic hematuria and variable proteinuria. And definitive diagnosis, culture, growth of Shigella or verotoxin producing E. coli on stool culture and detection of Shiga toxin by PCR or ELISA. Both toxins are there, Shiga and Vero. How to treat? Management of renal injury. In severe renal injury, we have to give dialysis support, either peritoneal dialysis or hemodialysis. Then anemia, so correction of anemia, blood transfusion in severe anemia, then control of hypertension, antibiotics for shigellosis. In atypical HUS, complement inhibitor, that is eculizumab or revolizumab, okay, and plasma exchange with FFP infusion. So plasma exchange only in case of atypical HUS, and immunosuppression for patient with anti-FH antibodies. Prognosis, typical or STEC, that is Shiga toxin producing E. coli, leads to hemolytic uremic syndrome, that is variable. Poor outcome in if there is oliguria or anuria for more than 2 weeks, severe neurological involvement, episodes of seizures or encephalopathy, and presence of cortical necrosis. And in atypical HUS, outcome is not good. Then ITP, previously it was called idiopathic thrombocytopenic purpura, now it is called immune thrombocytopenic purpura. If a patient will come, first we will take history and do physical examination and blood for total platelet count. So platelet count may be normal or may be thrombocytopenia, reduced platelet count. So if there is thrombocytopenia, what are the causes? Maybe if a child, it is a case of a child if presents with bleeding or rash, purpuric rash, okay. So if we get thrombocytopenia, what are the causes? These all are differentials of ITP. First, most common is infection, then hypersplenism, then thrombotic microangiopathy, malignancy, Fanconi anemia, thrombocytopenia with absent radius, that is called TAR syndrome, okay. Thrombocytopenia with absent radius, and platelet dysfunction, functional defects of platelet, not quantitative reduction but qualitative. And if platelet count we will get normal, then we will test further for PT, APTT, prothrombin time and activated partial thromboplastin time. If PT and APTT both are abnormal, then possibilities are liver dysfunction due to oral anticoagulants, deficiency of vitamin K or DIC, disseminated intravascular coagulation. So these 4 are possibilities if both PT and APTT are abnormal. If PT is normal but APTT is abnormal, that is Hemophilia A and B, that is due to deficiency of factor 8 and 9 and von Willebrand disease. And if PT is abnormal but APTT is normal, then what are the possibilities? Anticoagulant therapy and factor 7 deficiency. Qualitative disorders of platelet function. So, what are the platelet function disorders? Platelet count is normal, but platelet function is abnormal. Some are inherited, some are acquired disorder. What are the inherited disorders? Glanzmann thrombasthenia, then Bernard-Solier syndrome. Glanzmann thrombasthenia due to glycoprotein 2b3a deficiency and Bernard-Solier due to glycoprotein 1b deficiency. Then gray platelet syndrome, dense body deficiency. And what are the acquired causes? Drugs like aspirin, clopidogrel, chronic kidney disease, CKD and cardiopulmonary bypass. So, in these conditions, platelet count is normal, but function is impaired. Now, how to differentiate between platelet disorder and coagulation disorder? Basically, bleeding disorder and coagulation disorder. In platelet disorder, site of bleeding is skin, mucous membranes, but in coagulation disorders, the site is located more deep, that is soft tissue, joints, muscles. Petechiae will be present in bleeding disorder. Ecchymosis in platelet disorder will be small and superficial. And in coagulation disorder, ecchymosis will be large and deep. Then hemarthrosis and muscle bleeding. Site of bleeding in coagulation disorder is joints, muscles. So, hemarthrosis, muscle bleeding will be common in coagulation disorder, rare in platelet disorder. Bleeding after minor trauma will be present in platelet disorder. Even bleeding after surgery, bleeding after minor trauma and bleeding after surgery will be present in immediately in platelet disorder, and bleeding after surgery will be delayed in coagulation disorder, but that will be severe. So, from this history and examination, we can differentiate between bleeding disorder and coagulation disorder. Now, ITP immune thrombocytopenic purpura is the most common bleeding disorder in children between 1 and 7 years of age. Acute ITP definition is thrombocytopenia lasting less than 3 months, persistent thrombocytopenia for 3 to 12 months, and if thrombocytopenia persists for more than 12 months, then we will call it a case of chronic ITP. What is the pathogenesis behind this? Platelet demonstrate antibody. So, there will be antibody against the platelet glycoprotein 2b3a complex. So, when there will be antibody against the platelet, then platelet will bind and platelet with antibodies will be trapped in spleen and destroyed by splenic macrophages. So, there will be thrombocytopenia. Most common viruses, platelet, okay. So, platelet will be destroyed by splenic macrophages and there will be thrombocytopenia. Most common viruses associated with ITP are Epstein-Barr virus and HIV. Clinical features, how the patient will present. Patient will come in OPD or IPD emergency with history of sudden onset of purpura and petechiae. Okay. Otherwise, the child is healthy. Only complaint is petechiae and purpura, and that is of sudden onset. History of viral infection will be there 1 to 4 weeks before onset of thrombocytopenia. Mostly we will get the history of viral infection, but sometimes we may not get it. According to the symptoms, the ITP are classified. First, no symptoms, then mild, only bruising and petechiae, occasional minor epistaxis. Moderate ITP, more severe oral and mucosal lesions, and more epistaxis and menorrhagia. And in severe ITP, there will be episodes of menorrhagia, epistaxis, melena. Lab investigations. First, we will do a complete blood count. We will get platelet count will be low. If there is severe bleeding, then hemoglobin will also be low. Peripheral smear, we will get giant platelet. And we will also screen for if there is any blast cells or malarial parasite is present in PBS. Because one differential is leukemia. So, we will have to look out for blast cells. Then bone marrow, what will we get? Bone marrow study, increased production of megakaryocytes. Okay. And indication of doing bone marrow, we will not do bone marrow study in every case of ITP. If there is associated low hemoglobin count, low RBC, WBC count, then we will do bone marrow study. That is, if more than one cell lines are depressed or suppressed, then we will do bone marrow study. DCT to rule out Evans syndrome. Evans syndrome is autoimmune hemolytic anemia associated with thrombocytopenia. Then HIV, it's a cause of ITP, so HIV to be ruled out in high risk population. And ANA, anti-nuclear antibody to rule out SLE, systemic lupus erythematous. Mostly we will do this test in case of persistent or chronic ITP. Okay, you can see large platelet, that is giant platelet. Okay, this is left sided, this is peripheral smear, and this is bone marrow study. So, what are the differentials of ITP? Already we know. First, malignancy, leukemia, DIC, disseminated intravascular coagulation, infection. Then HUS, HUS is another DD. Then Fanconi anemia, heparin induced thrombocytopenia, Evans syndrome, Wiskott-Aldrich syndrome, HIV, SLE. In Wiskott-Aldrich syndrome, we will get small microplatelets. In ITP, we will get giant platelets. How to manage? Platelet transfusion is contraindicated unless life-threatening bleeding, platelet less than 10,000. Okay. So, we will not transfuse platelet unless and until there is severe bleeding, platelet count is less than 10,000. If there is no or mild symptom, then we will keep the child under observation. And counseling is important because there will be generalized petechiae and purpura. So we have to counsel their parents that it is benign, no treatment is needed. If there is severe or moderate ITP with mucocutaneous bleeding, then we will give IVIG. The dose is 0.8 to 1 gram per kg body weight for 1 to 2 days. And another is steroid prednisolone. Dose is 1 to 4 milligram per kg per day. So two drugs are there, one is IVIG, another is prednisolone. And for persistent or chronic ITP, there are other drugs like thrombopoietin receptor agonist, L-Trombovac and Romiflostim. And in chronic ITP and with severe bleeding is not controlled, then splenectomy is the option, and other biologicals like rituximab, cyclosporine. Then hemophilia. Hemophilia, the commonest hereditary clotting condition. Two types, Hemophilia A, Hemophilia B. Hemophilia A due to factor 8 deficiency, Hemophilia B due to factor 9 deficiency. Both are X-linked recessive. According to severity, hemophilia is classified mild, moderate, severe. Mild when the factor 8 or 9 is present more than 5%. Normally, in healthy population, it is present around more than 50%. So, factor level will be more than 5%, then we will call it mild cases. If factor level is 1 to 5%, then it's moderate. If factor level is less than 1%, severely low, then we will call it severe hemophilia. So, this is intrinsic pathway and extrinsic pathway, we all know. So, basically, factor 7 is involved in extrinsic pathway and factor 8, 9 is involved in intrinsic pathway, and common pathway factor 10, factor 5. Okay. So, we have to know this much basics. Clinical features, how a patient of hemophilia will present. Bleeding symptoms may be present from birth or may be present thereafter. Often undiagnosed in newborn. Easy bruising, intramuscular hematomas, hemarthrosis begin when child starts to cruise. ঠিক আছে, হামাগুড়ি খাবে, ঘষা লাগবে, তখন ব্লিডিং স্টার্ট হবে। Hemarthrosis is the hallmark of hemophilic bleeding because coagulation disorder mainly joints, bleeding occurs in the joints muscles. So, hemarthrosis is hallmark of hemophilic bleeding, and most common joints involved is ankle, knees, elbows. Okay. And muscular hemorrhage. If there is muscular hemorrhage, episodes of muscular hemorrhage, there will be pain and swallowing. So, this is a picture, child with hemophilia with knee hemarthrosis, okay, with severe pain, swelling, redness, okay, all symptoms or signs are present. There is collection of blood in the knee joint. That's why the knee joint is swollen and inflamed. Lab findings in Hemophilia A due to deficiency of factor 8. So, factor 8 will be reduced in Hemophilia A, factor 9 will be reduced in Hemophilia B. APTT, PTT will be prolonged, PTT or APTT, because factor 8 and factor 9 both are involved in intrinsic pathway that determines the APTT. But BT, bleeding time, prothrombin time, thrombin time will be normal. It is a coagulation disorder, not a bleeding disorder. Bleeding time will be normal, and prothrombin time, here intrinsic pathway is involved, extrinsic pathway is not involved. So, only factor 7 is involved in or activated in extrinsic pathway. So, prothrombin time will be normal and platelet count is normal. So, difference between platelet disorder or coagulation disorder, ITP was a platelet disorder, platelet count is reduced, thrombocytopenia is there. In hemophilia, it is a coagulation disorder due to coagulation factor deficiency. So, platelet count will be normal. What are the complications? Permanent disability due to recurrent joint and muscle bleeds. Then, if there is bleeding into CNS or upper airway, that will be life threatening. Most severe muscle bleeding occurs in iliopsoas muscle. Okay, iliopsoas muscle can trap a large volume of blood. That's why the patient with iliopsoas muscle hemorrhage may go to hypovolemic shock. And that is one term, that is termed inhibitor. In termed inhibitor, there is production of antibody against the clotting factor. Clotting factor is not deficient like typical hemophilia, but there is antibody against the clotting factor that makes the clotting factor ineffective or non-functional. Treatment, how to treat? First, preventive measures, avoid contact sports, trauma, okay, that will lead to injury to ankle, knee, elbow. So, avoid this type of sports. And drugs like aspirin, NSAID, NSAID, non-steroidal anti-inflammatory drugs, and intramuscular injection. Okay, so intramuscular injections we should not give in hemophilia patients because there will be muscular hemorrhage. Then tranexamic acid, it will prevent the conversion of plasminogen to plasmin. This plasmin disrupts the clot. So, tranexamic acid inhibit formation of plasmin. But there is one absolute contraindication for prescribing tranexamic acid, that is presence of hematuria. Okay, because ureter will be blocked. So, we will not give tranexamic acid if there is associated hematuria. Then epsilon aminocaproic acid, it is an antifibrinolytic agent. So, we can give in case of hemophilia, mostly in mild hemophilia. Local pressure at bleeding site, if bleeding is there from any side, then local pressure will prevent the bleeding, further bleeding. Then Desmopressin acetate. Desmopressin acetate increases the factor 8 levels. Again, it is helpful in only mild hemophilia. Dose is 0.3 microgram per kg body weight. And for hemarthrosis, rise like rest, ice application, compression bandage and limb elevation. And aspiration of joint strictly avoided. These are all supportive management like physiotherapy, regular gentle physiotherapy, vaccination against hepatitis B, because there will be episodes of bleeding, and patients exposed to plasma derived product, we have to screen regularly those patients for serology, hepatitis B, C, HIV and abnormal liver function. And genetic counseling is required as this condition is X-linked recessive. These all are supportive managements. Definitive treatment is for hemophilia A, concentrated factor 8. The dose, the desired rise we want in factor 8 level. It is the difference between the optimum level of factor 8 and the level of factor 8 in patients of hemophilia, multiplied by body weight multiplied by 0.5. Each unit of concentrated factor 8 increases the factor level by 2%. So, if there is severe factor deficiency, we have to give more concentrated factor 8. Like in hemarthrosis, the dose is 20 unit per kg every 12 to 24 hours for 1 to 2 days. Okay. To achieve target of 40% factor 8. If we achieve the target of 40% factor 8, then it is sufficient to prevent joint bleeds or hemarthrosis. But in case of intracranial hemorrhage, we have to achieve the factor level 80 to 100%. So, 80 to 100% correction is needed. So, the dose will be 50 unit per kg every 12 hours for 7 to 10 days. So, depending on severity and location of bleeding, the dose of concentrated factor 8 will be changed. And cryoprecipitate we can give, that contains factor 8, von Willebrand factor, fibrinogen. So, we will get factor 8 in cryoprecipitate. Again, and FFP. Again, in FFP we will get factor 8. In hemophilia, we can give FFP and concentrated factor 9. But we will not give cryoprecipitate because cryoprecipitate does not contain factor 9. Cryoprecipitate is only helpful for hemophilia A. And concentrated factor 9 dose is the percentage of desired level multiplied by body weight multiplied by 1.3. Each unit of factor 9 per kg increases the factor level by 1%. In hemophilia A, it was 2%. And hemophilia patient with inhibitors that we discussed previously, termed inhibitors. So, there is not deficiency of factors, but antibody against the factors. So, if we will give the concentrated factor 8, factor 9, FFP or cryoprecipitate, that will be of no help because antibody or inhibitors are there. So, we have to give the bypassing agents. What are they? Recombinant activated factor 7, Novo 7, okay, and activated prothrombin complex like FEIVA, that is factor 8 inhibitor bypass activity. So, either Novo 7 or factor 8 inhibitor bypass activity. So these are the bypassing agents will give in case of turned inhibitors. And some non-factor products are there, that is emicizumab, is a monoclonal antibody, bypasses the function of factor 8, given subcut every 1 to 4 weeks. Other agents are concizumab, fitusiran. Okay. In prophylaxis in children with hemophilia, there are 3 types: primary, secondary, tertiary. Primary prophylaxis, initiation of prophylaxis before the child attained the age of 2 years and before or after the first joint bleed. Then secondary prophylaxis, the initiation of prophylaxis will be after 2 years age or after more than 2 episodes of joint bleeding. Tertiary, initiation of prophylaxis after the formation of target joint. So when we are starting the prophylaxis, initiating the prophylaxis, depending on that, it is classified into primary, secondary, tertiary, just like prevention, primary, secondary, tertiary. And for children with severe hemophilia, factor replacement will be 2 to 3 times per week. That is almost every alternate day. We have to replace the factor because the half-life of factor is factor 8. Half-life of factor 8 is 8 to 12 hours and half-life of factor 9 is 24 hours. So in severe hemophilia, we have to replace the factor, concentrated factor, 2 to 3 times per week.